When I'm doing an analysis and the results pop up on the computer, I'm the first person in the world to know that new knowledge. And I think that's pretty cool.
Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Welcome to That's Derm Good. Today, my guest is Dr. Lee Wheless. Dr. Lee is the Assistant Professor of Dermatology at Vanderbilt University Medical Center, board-certified dermatologist, epidemiologist, and data scientist who serves as Assistant Professor at Dermatology at Vanderbilt University Medical Center. Also holds an adjunct appointment at the Division of Epidemiology and works as staff physician at the Tennessee Valley VA Medical Center. So thank you so much for joining me, Dr. Wheless. It's a pleasure to have you on the show.
Oh, well, certainly. Thanks for having me, and thanks for your interest in my work.
Yes, so exciting. Lots to unpack here.
Well, certainly. I think it's important to get things out in non-doctor speak sometimes.
Yeah. So tell me a little bit about your background. How did you even get into dermatology and epidemiology? Was that something that was always on your mind?
No, I mean, I have always been kind of a math and science guy. And I thought, or when I was going into med school, that I would be, some kind of oncologist. And I thought, maybe surgical oncology or something like that. And I started working on, skin cancer project after my freshman year of college. I was working on melanoma immunotherapy in the days before we had the new checkpoint inhibitors and the actual highly effective immunotherapies. And then when I got to grad school, the project that I was wanting to work on, I wanted to learn genetic epidemiology. This was in the days before we had genome-wide association studies, and that was really just kind of on the very cutting edge of it. And I thought, that's something I want to learn how to do. And it turns out that the project that I got involved in at that point was also a skin cancer project. It was looking at basal cells and squamous cells and other, the keratinocyte carcinomas. And so after doing the summer doing melanoma research, 5 years of other skin cancer research, I thought, let me actually think about doing dermatology. And I really was able to discover that dermatology is such a cool field and that it's probably the only one where we're involved in the primary prevention of cancer. We're involved in the diagnosis of cancer. We're involved in the treatment of cancer. We're involved in the long-term follow-up of these patients. And we really see just the full spectrum of being able to longitudinally manage so many aspects of that cancer journey for these patients. Yeah. And so that's really what made me fall in love with dermatology.
That is such a really good point. I love how you said you see patients, you're actually preventing and you're also diagnosing and treating all of that at the same time, for which a lot of specialties, they send you off to a specialist to treat something. So I love that. Tell me a little bit about what exactly is epidemiology for any listeners that have not really heard that, which it's not very common, I don't think, talk about.
So epidemiology is the study of patterns of disease in populations. And it really gives us the ability to understand, what are actual causes of disease, what is not, what are some of the risk factors associated with getting a certain disease, with having a certain side effect from a treatment, and things like that. Epidemiology is really kind of a more quantitative aspect and kind of numbers and math-based aspect of science.
Okay. That's really cool. So you spent over 2 decades working with data. What excites you about the intersection of research and medicine?
I don't know. I still think that, when I'm doing an analysis and the results pop up on the computer, I'm the first person in the world to know that new knowledge. And I think that's pretty cool. So
it is. Because then it helps you, it prepares you for anything that's coming into your office.
Yep. And for this project in particular, not to jump right into it too much, but with nicotinamide, when I saw the results pop up on the screen the first time, I just kind of sit back and said, wow, is this real? This looks a little too optimistic. And redid it a couple times just to make sure and got the same answer every time, even pulling the data set several different ways.
Okay, so let's talk a little bit about that. Tell me what is nicotinamide, and tell me a little bit about it.
Nicotinamide is a water-soluble form of vitamin B3. It is an over-the-counter supplement that has been in use for decades, and really since about 2015 or a little bit before, we've been using it as a way to prevent skin cancer. There was this nice study of about 400 patients done in Australia that showed patients who took nicotinamide had about a 23% reduced risk of developing new skin cancers after 1 year.
Wow.
And so we all thought, hey, that is great. If we can cut someone's risk that much, let's definitely start using this in patients.
So is that something that anyone can say, okay, I'm just going to go ahead and start this? Or is that something that you would diagnose and say, hey, this is why you should be doing
as an over-the-counter supplement, it is something that folks can get on their own. The studies that were done, all of the patients specifically did have skin cancer. And in the study that we did also, every patient had skin cancer. So we don't know if this is something that in patients who haven't had it or aren't really at risk for developing it, if it would be beneficial for them. But that'll be something that hopefully down the line we'll get some good evidence to tell us one way or another.
So is this all types of skin cancers or specific?
So we specifically were looking at basal cell and squamous cell carcinomas, which are far and away the most common types of skin cancer. There are more of those two skin cancers than every other type of cancer combined every year.
Wow.
So extraordinarily common. Fortunately, they are also very, very treatable when caught early, especially. And so we don't hear a whole lot about them because they tend not to have the same mortality as things like melanoma that I think we all are much more familiar with.
If somebody has squamous cell or basal cell, is there more of a risk for them finding another spot somewhere else? Is it, is that common?
Yeah, there's decades of work showing that with each subsequent skin cancer that you get, you are more likely to develop another one. And so it's kind of once that horse is out of the barn, we can probably expect to see more skin cancers. And really, we want to prevent that from happening. And that's kind of the goal of what my group has been doing for the past few years.
So are you researching different reasons as to why that might be happening, or how else to prevent it? Absolutely.
One of the things that's been frustrating for me is that, because there are so many skin cancers every year, there are no cancer registries that capture these in the U.S., and we don't have great data for how common these are, who gets them, and things like that. And so to be able to study multiple skin cancers, we had to first come up with ways of being able to identify them and pool large cohorts together. And with a couple collaborators up at Brigham and Women's and MD Anderson, we did get a sample of something like 5.5 million skin cancer patients.
Wow.
And we found that about 40% of patients are going to be developing that second skin cancer. But another way, that means that about 60% of the patients that were in this study, the study window was round about 10 years, depending on which cohort they were in. But within round about 10 years, 60% of patients who had that first skin cancer did not develop a second skin cancer. And so that's one of the reasons why I kind of hedged earlier of, should everybody be taking nicotinamide? It's, some people might not be seeing any benefit of reduced skin cancer risk because their risk is essentially zero.
Right. So what all are you looking at? Is it lifestyle, like foods that you're eating, the environment? What all plays a huge factor in getting skin cancer and not having it return?
Yeah, well, by and large, the number one driver of skin cancer risk is exposure to ultraviolet radiation and how an individual's skin deals with that. Now, folks who have very fair skin and lots of sun exposure are going to have an extremely high risk of sun damage. And this is where when I'm talking with my patients, I always discuss the difference between relative risks and absolute risks. And so say you are, taking a medication that increases your risk by 20 or 30 times. That sounds really scary.
Mm-hmm.
Now, if you are someone who is already at high risk for skin cancer based on your skin type, you really need to be careful, be wearing sunscreen, hat, long sleeves, taking, any kind of preventive agents that we can to reduce that risk, because a 30-fold increase is huge.
Mm-hmm.
But if you have a darker skin type and your skin just doesn't accumulate a lot of UV damage, then, 30-fold increase of what is an extraordinarily low risk is still extraordinarily low.
Mm-hmm.
And so that's, our relative risk is up by 30, but I always show patients, if your risk at baseline is this, 30 times that, still that.
Right.
So it all has to be individualized.
So if there's someone who has a very fair skin tone, which, okay, this is my sister, for example, she had skin cancer, but it was an area that was not exposed to the sun. What would those risks be like, for someone who has had skin cancer? I mean, it's been years. She, gets her skin checks often. What are the risks there for that returning? Or is that even something? Is it hereditary? Does it run in the family?
So a lot to unpack in those questions. But I guess one of the answers is we're still trying to figure out, some of the non-sun mechanisms.
Mm-hmm.
Certainly genetics does play a factor in some of these skin cancers. We know that melanomas in particular that arise on sun-exposed skin versus sun-protected skin do have different genetics, and they behave differently. And sometimes we use different treatments for them as a result of that. So we know that they are different, but also we know that things like basal cells are related to more kind of acute intermittent sun exposures. So that person who goes to the beach once, gets a nasty blistering sunburn, and protects their skin very well the rest of the year. Whereas squamous cell carcinoma is more related to that chronic accumulation of sun damage. Mm-hmm. So those people who have jobs where they're working outside, they're in the sun all the time, people who live in Hawaii or Miami or somewhere that it's hot and sunny year round. And so it can be hard to understand, why did this skin cancer on a relatively sun-protected area pop up? Mm-hmm. Certainly it could be just the bad luck that the one time it did get an intense sun exposure, we developed that mutation.
Mm-hmm. Wow. There's so many different factors. That's why there's research needed, right?
Exactly. It keeps me working hard.
Yeah. Wow. It's kind of crazy how that works. And, there's still just so much learning that we can do. And, generally. So if somebody, you say they go to the store and they find this product and they're like, oh, this is going to help prevent skin cancer, mm-hmm. Not necessarily having it before. And then they go off and they think that they're just going to be protected. And I mean, how do you protect people that are just going to the store and don't necessarily know what they're getting?
Mm-hmm. Yeah. And that's the tricky thing, is that currently in the U.S., the over-the-counter supplements are not regulated. Mm-hmm. And so you can't always be 100% certain as to what you're getting. Now, most of the companies that are out there, I would hope, are doing their own independent testing and doing a very good job of making sure that exactly what they say is in there is in there. Mm-hmm. And nicotinamide is a, relatively safe supplement for us to be taking, especially at the doses that we looked at in the study. We looked specifically at 500 milligrams twice daily. Mm. We do know that at doses of about 3,000 milligrams daily, so 3 times the dosage that we are recommending, that you can start getting some side effects, namely some GI upset, some muscle cramps. People who have kidney issues can get low platelets and kind of clotting issues and get some bruising and bleeding. Mm-hmm. So it's at higher doses, it is something that we need to be mindful of. And then kind of the bigger thing that fortunately hasn't really panned out in some of the studies that I and others have done is there was a paper that came out about 2 years ago suggesting that one of the metabolites of actually a cousin of nicotinamide called niacin, but molecularly they are pretty identical and metabolized nearly the same way. There was concern that metabolites of this could increase a person's risk of heart attacks and strokes. Mm. We definitely do not want to be causing heart attacks and strokes to try and prevent you from having a very treatable skin cancer. Mm-hmm. And so before doing the study on does nicotinamide actually work at preventing skin cancers, this is the reason that I got into looking at nicotinamide in the first place is, are we harming our patients by recommending this? And so I did a study in 2 cohorts in Vanderbilt and the national VA population, really looking at, in the patients who are getting nicotinamide, let's control for all of these cardiovascular risk factors. Let's control for how long they've had these, for when they were diagnosed with all these risk factors, to really try and make sure that they're as close to equal cardiovascular risk as possible. And the only difference was, did they or did they not get nicotinamide? And what we found is that in the VA population, so this is a population who's at really high risk for cardiovascular disease as it stands, we did not see any increased risk of heart attacks or strokes or, all combined, we call them major adverse cardiovascular events, or MACE. And so we didn't see any increased MACE in the veteran population. A downside of that study was that for the patients who didn't get nicotinamide, we had to impute their start date, which essentially means we had to use a lot of fancy math and make up when they started. And so to get around that, what we did was we also looked at a sample from Vanderbilt where it was documented in the chart that, we are recommending they start nicotinamide. And most of the patients that we recommended that for did start it, but there was a subset of patients who did not start nicotinamide. And so we've got, the exact date that this was recommended, and we were able to follow those patients and see, is this increasing your risk of MACE? And fortunately, in that in that different population, we found the same result, in that there was no increased risk of MACE. So that gave us a lot of reassurance.
Yeah, that's great. Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Is there ever any instance where it would be in a multivitamin or any issues with taking multivitamins as well?
I have not specifically looked into the components of different multivitamins. I'm sure some of them probably do have nicotinamide, and I don't know if they're at the level that would be, helpful for reducing skin cancer risk. A lot of supplements are going to be just nicotinamide by itself, or it might be with, 1 or 2 other things.
Oh, okay.
Now, I like to make sure that people understand. So there are the naming conventions for the B vitamins can be kind of tricky. So I call it nicotinamide. Another identical name for it is niacinamide. Now, the important thing is that it ends in amide, because there is also nicotinic acid and niacin, which that is a very different form of vitamin B3.
I recognize those.
Yeah. That is one that is not studied for skin cancer prevention. And that is one that if you take it, you will quickly discover that it has a very wonderful side effect of causing some pretty intense flushing of your face and just feeling hot all over. It's one that a number of years ago we used to use in cardiovascular disease to reduce your risk of heart attacks and strokes and things like that. Since we have statins out now, that's really kind of fallen out of favor, but it's still out there. People still take niacin. And if you inadvertently get a bottle of niacin and you're popping those and you get that flushing, you did not get nicotinamide or niacinamide. You got the wrong thing.
So there's definitely consulting that they need to do with their dermatologist before they just start taking supplements or self-diagnosing.
Absolutely.
Not going to Dr. Google. I feel like that's always now or ChatGPT, which should I take? So, yeah.
Absolutely. And what we're hoping is that with the data that we've put out, that we will be able to develop some guidelines to say, when should we be starting nicotinamide? Because that's been one of the weaknesses, is that it's still been this kind of ethereal time point of when do we do it? Is it, right after that first skin cancer? Do we wait until they've, developed a lot of skin cancers and said, oh, you're a high risk patient. Maybe we should start you on nicotinamide. Mm-hmm. And in fact, the two big studies that looked at skin cancer prevention in patients on nicotinamide, everyone in those studies had at least 2 skin cancers, and as many as, I think, 78 was the highest in the one trial, and the average was about 7 or 8 skin cancers. Wow. And that's really important, because what we found in our study was that the earlier that you started nicotinamide, the greater the benefit you were seeing. Such that, overall, we found a 14% reduced risk of skin cancer in patients taking nicotinamide. If you took that after the first 1 or 2 skin cancers, we're seeing roughly a 50% reduction in skin cancer risk. Wow. But if you waited until, the 7th or 8th skin cancer, we're really not seeing any remaining benefit. Mm-hmm. And so it kind of, it changes what we've been doing, because for the longest time, we've been waiting until a patient declares that they're this high-risk skin cancer superproducer and then starting. But these data really show that if we wait that long, the horse is out of the barn, and we need to be, acting sooner.
Right.
And if we think about the mechanism of how nicotinamide works to prevent skin cancer, this actually makes sense. So we think that the way nicotinamide works is that it's providing additional energy sources to, highly energetic processes like DNA repair. Mm-hmm. And so in patients who have just a little bit of background sun damage, as might be evidenced by having just 1 or 2 skin cancers, their baseline sun damage is right around here. If we slow the rate to get up to that threshold where you're going to develop another skin cancer, that's going to slow the amount of time that it takes us to get up there, and really slow when we are getting more skin cancers. Mm-hmm. The other end of that spectrum is if we have just really high background sun damage, we've already had lots of skin cancers, and we already are kind of up here with where our sun damage is. Even if we're slowing that rate, it doesn't take much more to tip over that threshold. And so we're just not going to be seeing the same benefit.
So I know there's a lot of technology out now, which I know I've done a few different ones, where there's like a scan that you can do on your skin, and it tells you how much skin damage you have, like sun damage and all of that. Would that be a good way to kind of pair that, if anyone has any concerns, or even just kind of a regular treatment almost, is doing this scan to see, okay, what are the risks here? If you've got a lot of skin damage, or if you've gone to a dermatologist and they're like, hey, we need to check your skin, kind of doing that in-depth photo. I can't remember what it's called. I know I had one before where it was like, and it showed me a picture of my skin, and it showed like, okay, this is sun damage here. And this is, not necessarily that there's cancer there, but it shows you where that sun damage is and what those risks could be if you don't start protecting your skin. But something like that, kind of paired with taking an oral would be really beneficial, right?
I think we're still waiting to get data to see what the correlates are with that. Mm-hmm. But no, that's absolutely something that we are looking into, because the goal is, with precision or personalized medicine, is getting the right treatment to the right patient at the right time. And if we can find patients who, they do have that background sun damage that might not be clinically apparent, but we are able to detect it in other ways, and they are high risk for developing skin cancer, and they are going to benefit from nicotinamide, the sooner that we can identify those patients, the better.
Mm-hmm. Yeah. So you're also involved in, I guess, treating organ transplant recipients. Why is this population particularly vulnerable to skin cancer?
Yeah, so that's a complex question. So just a little bit of background. Solid organ transplant recipients historically have had about a 30 to 100-fold increased risk of developing skin cancer. And metastatic squamous cell carcinoma is a pretty significant cause of certainly morbidity, but also mortality in these patients. So patients are dying from non-melanoma skin cancers. And so it's really important to be able to identify who these super producers are. And that's kind of what got me into this whole thing of multiple skin cancers and skin cancer prevention, is having so many of my transplant patients with so many skin cancers. But really the big thing with them is kind of twofold, is that a lot of these medications, they're knocking down your immune system, and because, otherwise you're going to reject your organ and that's it. And so to have your transplanted organ, you have to have some degree of immunosuppression for the rest of your life. And so with your immune system knocked down, you don't have the same degree of immune surveillance. And so our immune system is always going through our body, finding cells that are trying to turn bad, wipes it out before we even know anything was there. Great. When we knock the immune system down, it can't do that quite as effectively. And so that maybe that one little spot that never would have amounted to anything before has the ability to just persist and accumulate more mutations and eventually can turn into something like a skin cancer. And that absolutely can happen, but that's not really the big thing. And what I think is the biggest thing is that a lot of these medications, and especially some of the older medications that we've been using that fortunately are falling out of favor these days, is that they really block the skin's ability to repair sun damage. And so if we're not able to repair all that sun damage, it makes perfect sense that we're going to be getting lots and lots of skin cancers. And so I always tell my patients then is that if we're not getting that sun damage in the first place, we're not going to be seeing that really high risk of skin cancer. And so things like sunscreens and hats and long sleeves and sun protective clothing, and now, supplements like nicotinamide or other treatments like acitretin, which absolutely is a prescription only, why those really are so important, because if we can not be getting damage in the first place, there's your prevention and we're not going to be seeing the skin cancers.
Right. So what does that care look like for patients who develop multiple or aggressive skin cancers? Are they coming in like 6 months or sooner than that?
It depends on the patient. We do have some nice guidelines by some of my colleagues at MD Anderson and UT Austin and Brigham Women's, and probably missing where everybody is, but something called the Sun Track, or I'm going to baffle the acronym, but it's pretty much the skin cancer risk stratification model. And so that tells us, based upon just a few factors at the time of transplant, what is your risk for developing skin cancer in the next 5 years? And so based off of that, we can say, we need to see you, within a year or two after transplant, and we'll kind of go from there. People that are the highest risk, so folks who are over 50 years old at the time of transplant, folks who have already a skin cancer at the time of transplant, males, people who have a thoracic organ transplant, and I think one other variable that I'm probably forgetting that I'll think of later. All those combine to form the nomogram for the Sun Track score. But I have patients who, I would see about every 6 months, and they're doing fine, and we have them on a pretty steady regimen. We have them on some chemo prevention like nicotinamide, like acitretin. Sometimes we'll do topical treatments to really try and reduce their background risk. I have patients who I have had to see every month or sooner because they just keep popping up with more and more skin cancers. And then I have some patients that I say, hey, you look great. I'll see you in a year.
Yeah. So it's very personalized for sure.
Yeah.
So as far as you do clinical trials as well, and you're involved in the regulatory processes, what role does your research play in supporting these clinical trials and designing these trials?
Yeah, so right now, I kind of alluded to this earlier in that all the studies have been looking at nicotinamide use in patients with skin cancer. Right now, we are developing a trial to look at, is nicotinamide effective for primary prevention of skin cancer for those patients who have not had skin cancer before. As you can imagine, that really casts a much wider net than just the folks who have had skin cancer. And so even among patients who do not have skin cancer, there is an extraordinarily broad range of what is your risk for skin cancer. And so we're going to be looking at first at patients who we know do have some kind of background risk for skin cancer based on a number of different variables and see, is this effective at prevention? And then beyond that, we can look and see. But we always want to be incremental with what we're studying, what we're trying to assess and recommend to our patients.
Yeah. So when you're doing these studies, I'm fascinated by clinical trials. I think it is really cool how they work and, just the outcomes that you see. Are you actually just testing people, having them be put on this medication and then just kind of going through that process, or what does that look like?
I mean, pretty much that's the biggest thing is that doing these trials, they take a lot of time. And that's a lot of expense that goes into it. Because if looking at the results that we did see in this study, if I reduce the risk or the rate of skin cancer by 50%, say in 5 years, 6% of patients develop skin cancer. So we take it from 6% down to 3%. To be able to get statistical power to say that is a true difference of 6 versus 3, that can take thousands of patients.
Yeah.
And so for really uncommon outcomes like 3 versus 6%, that's a huge, huge trial. So that's why we always try and focus on the higher risk populations. Because if all of a sudden we say that, the 5-year risk of developing skin cancer in this population is 30%, it's a lot easier to statistically say 30 is different than 15, and 6 is different than 3.
Right.
So again, that's our whole issue of relative risks versus absolute risks.
Yeah. So I know you said higher risk. Is that like your qualifications for anyone that goes into these trials? Are they specific? You have to be using sunscreen, or like, what are some of the specifics that you have for anyone that is in one of these?
Oh man. Well,
I feel like there's so many, like you said, it's a wide net.
Yeah. And you always want to strike the right balance of, can I control every single factor in here and find out exactly what the effect is of this medication versus, okay, great, but these are highly neurotic patients who are going to do exactly everything by the book and never miss a single application of sunscreen, never miss a single pill, or always going to be wearing a hat and long sleeves every second that they're outside of the house. But that's not the real world. And that kind of intervention is just not going to be feasible in the vast majority of your patients. And so being able to balance the two of them, of internal versus external validity and generalizability.
Do you think that's one of the reasons why these cancer clinical trials seem like they take so much longer to try to really get a conclusion for things?
In part, I think it's for a lot of the cancer clinical trials in particular, where the risk of death is so much higher than it is for developing a first skin cancer. Then you have kind of the added complexity of, could I potentially harm this patient? Is this something that if I do nothing or I put them on the standard of care, they're going to have, X number of months or years still to live. And this other treatment that we think is more effective, a lot of them end up not being more effective. And so you really want to be very, very certain and have rigorously studied and know that this is going to help people, because the worst thing that we can do as a physician is harm our patients. I mean, that's the Hippocratic Oath, is do no harm. And so it takes so long because we want to be really certain that this is better for our patients than what's out there.
I like that. So as far as what is happening in the future for you, as far as what advice would you give to medical students and residents interested in research or precision medicine and when they take that oath? I mean, that's really powerful.
Yeah, I mean, it's interesting times right now to be in medicine and in biomedical research. I still think it is rewarding. I still have fun doing all of this. I'd still do the same path again. The only constant is change, and we all have to evolve and see what comes next.
So my last question for you, what does success look like for you over the next few years, clinically, academically, or personally?
I don't know, just taking good care of my patients, hopefully still finding things that are going to help patients both in my clinic and across the world. And, if I can do those two things, I think I'm happy.
Well, thank you so much, Dr. Wheless. It's been such a pleasure talking to you, and
likewise.
Really good information. I mean, it's amazing what you do and what you're continuing to do. The research is so much needed, and hopefully we'll stay connected and hear more about some of your clinical trials and follow how things go.
Awesome. Thank you so much.
Yes, thank you. Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.